Hey everyone, welcome to the UNC Neurosurgery Med Student Primer Series. I'm Marty Piazza. I'm one of the neurosurgery residents, and we're picking up with part 2 of our traumatic brain injury set. We previously talked about some definitions of TBI, and then this section is going to be about specific types of injuries, particularly hemorrhage patterns that you can see in traumatic brain injury patients. So some common types of head injury that can result in TBI, there's several types of hematomas. There's epidurals, subdurals, subarachnoids, interparenchymal hemorrhages, and interventricular hemorrhages. You can get traumatic contusions and as well as fractures that can be linear, depressed, comminuted. They can be open, exposed to the air, or closed, and then diffuse axonal injury. So the CT scan without contrast is the workhorse for evaluating patients with a TBI. It's fast and it can diagnose many operative emergencies. In general, when evaluating blood products, hyperdense or white is going to be acute blood, and hypodense is which is darker, is going to indicate old blood. In rare cases, we'll catch something with active extravasation, which is hyperacute blood, and this can also be dark, but there's a noticeable whirling pattern that is different from an old blood pattern. Here we have an epidural hematoma on the patient's left side. It's hemorrhage between the skull and the dura, which is limited by the periosteal layer. So hemorrhage in this pattern is going to stop at the sutures, and it develops this lens or biconvex shape. Most commonly, you're going to see an epidural hematoma due to middle meningeal artery tears. This artery is just underneath the squamous portion of the temporal bone, which is very thin. You'll often see a skull fracture at this location as well. Anecdotally, patients are usually children and young adults. They have concussion-like symptoms initially that resolve, and then it's classically going to be followed by this lucid interval while they're awake and seem normal, and then suddenly they decompensate due to compression of the brain. Treatment for an epidural hematoma is usually emergent surgery for craniotomy for clot evacuation. These patients typically have a good outcome if it's caught in time, as the neurologic changes are pretty fast and rapid, and they're due purely to extradural compression and not necessarily initial damage to the brain itself. So that's important to note when you're comparing this outcomes of this bleed with a subdural hematoma. Classic epidurals are due to arterial injury and require surgery. However, occasionally a patient may have a venous epidural hemorrhage, typically from the highly vascularized bone in children is when I've seen it most frequently, and that may not require surgery if the patient is clinically stable and there's no expansion of the hemorrhage on repeat imaging. These venous epidural hemorrhages are usually not seen in the classic location either, but rather they can be kind of anterior frontal or anterior temporal fossas. So in contrast, subdural hematomas are hemorrhages in between the brain tissue and the dura. They can vary in appearance on CT due to the age of the clot, so they don't have to be acute. But an acute subdural, which is also going to appear hyperdense on CT like you see on the left here, can warrant emergent surgical evacuation if there's a neurologic deficit that correlates to the hemorrhage and or the clot is greater than 1 centimeter in size and greatest diameter. Acute subdural hematomas are going to have higher morbidity and mortality than epidural hematomas, like I mentioned before, and that's because subdural hematomas indicate that there's also underlying brain injury, whereas an epidural hematoma, the neurologic deficits you get from that are purely due to compression from an external source. A subacute subdural hematoma, as you can see in the middle picture here, will have a mixed density or an isodense fluid collection. And then a chronic subdural hematoma appears hypodense, as you can see on the right picture, and you'll have this kind of a chronic appearing crescentic isodense fluid collection. Note that the subdural hematomas don't respect the suture lines like an epidural does. And so you can have a holohemispheric subdural collection. Chronic subdural hematomas can also present without a history of preceding trauma. They can be observed or evacuated depending on the symptoms. Evacuation of a chronic hematoma is going to be recommended if the patient has a focal neurologic deficit, a change in mental status, seizures, severe headaches, or on serial imaging, the fluid collection is getting bigger. Typically, acute subdural hematomas requiring evacuation will be too thick to evacuate with burr holes, and they're going to require either a craniotomy or a craniectomy depending on the status of the patient. If the patient has no focal deficits, or if the patient presents late over several days after the injury, burr holes can be possible, and the reason for that is because that clot's going to liquefy with a little bit of time, and so you can irrigate it out as opposed to taking it out. So subarachnoid hemorrhages. So you can see subarachnoid hemorrhages, classically we think about aneurysm ruptures, but they can also be seen in traumas. But it's important to distinguish the two, and they're usually pretty easy to tell the difference, and because the pattern of blood is quite different. On the left scan, you can see that you have this diffuse hemorrhage that looks centrally focused. That's suggestive of an aneurysmal subarachnoid, whereas on the right, on a traumatic subarachnoid hemorrhage, you just kind of see this focal, high cortical, almost subarachnoid hemorrhage pattern. And the patient history is also going to be important. Sometimes a patient will come in with a head injury after a car crash, and if there's any concern that there is an aneurysm after looking at the imaging study, it's important to know, did the patient crash the car first, or did they lose consciousness and then crash the car? Because that's going to be an important factor when you're determining how to treat this patient. If there's any concern or doubt, you can always get a CTA to look for an aneurysm as well. So trauma patients can present with IPHs as well. Some underlying causes of IPHs outside of trauma are chronic hypertension, amyloid angiopathy, and hemorrhagic conversion of an ischemic infarct. In the case of a hypertensive IPH, 50% will occur in the basal ganglia and 15% will occur in the thalamus, 10 to 15% occur in the pons. Surgery is going to be reserved for patients that are felt to have brain injury due to compression or elevated intracranial pressure, given the high-priced real estate of these hemorrhage locations. Neurologic deficits are going to be expected and won't likely improve with surgery unless there's a pressure problem. Now, you may see these IPHs as a result of a trauma as well. They're not going to be quite as deep as you would see with a hypertensive hemorrhage. They will be kind of on the cortical surface, but hypertensive hemorrhages are going to be more commonly in the basal ganglia. So IVHs, or interventricular hemorrhages, are obviously hemorrhages within the ventricular system. It's less common with trauma, but it does happen sometimes, and when it does, it's usually associated with DII or diffuse axonal injury, deep gray matter injury, or brainstem contusions. And it's thought that isolated IVH could be due to rupture of the subependymal veins. IVH can be dangerous, especially if there's some obstruction of the ventricular system, which could lead to hydrocephalus that may require an external ventricular drain, or an EVD. So traumatic contusions are seen quite commonly in patients with severe TBI. They can be associated with this coup contra coup phenomenon, which, if you remember from studying for step 1, there can be 2 injuries to the brain with 1 blow to the head, and that is the coup injury, which is the damage to the brain directly under that blow to the head, and then there's a contra coup injury, which is due to the brain hitting the skull on the opposite side as the skull decelerates, but the brain doesn't. And so, for example, you can have a direct blow to the head on the right frontal region, but you'll also have some contusions on the left parieto occipital region of the brain as well, and that's the coup contra coup. Contusions can develop worsening edema and blossom as well, especially in patients that are taking blood thinners, even daily aspirins, or in North Carolina, a lot of patients take goodie powders for headaches, which have high doses of aspirin in them. So they're at risk for developing increase in hemorrhage from these contusions. Surgical evacuation can be indicated in these patients if there's excessive mass effect. If there's any concern about their neurologic status right off the bat, you can always put in an ICP monitor to measure their pressure as well. So let's stop there for now, and then we can reconvene next time and talk about different types of skull fractures, DAI, and then treatment paradigms for TBI patients. See you then.